Namaskar, dear viewers. Welcome to Critical Lines podcast, another session. And we hope that you are finding it useful. And I'm received some messages saying that you are finding it very useful. So that's great. The idea behind these 20-minute sessions is to give you consolidated, updated information in just 20 minutes and explain the key concepts. We keep it short and sweet because I think the audience retention beyond 20 minutes is very difficult, and it's difficult for the speakers also to go on beyond 20 minutes. And in case you are wondering, we share the questions with the speakers beforehand so they can kind of brush up, look up the latest literature, and put their thoughts together. It's the best that way. So today we have a very eminent speaker, Dr. Atul GOGIA. Sir is at Gangaram Hospital, New Delhi, which is one of the premier institutes in our country. So, sir is senior consultant and head of infectious diseases at Gangaram Hospital, New Delhi. He's on the editorial board of CMRP Journal and reviewer for many national and international journals. He has more than 120 publications and several book chapters in internal medicine and in infectious diseases. And he is also the convener for Clinical Infectious Disease Society of India, Delhi chapter, and he's a recognized DNB teacher. So he has many laurels to his credit, and he has been a great teacher and a great contributor also to Young India Intensivist. And last but not the least, he's a senior faculty of a Young India Intensivist. So we'll kick off now. So the first point for discussion is about tuberculosis. So tuberculosis has seen advances in the recent times, sir, in terms of diagnosis as well as management. So could you talk about them?
Yeah, good evening. Thanks, Dr. Tapesh, for having me here today. And it's been really heartening to see the way you've been continuing this group and you've been doing all these webinars. It's really amazing. Hats off to you. Thanks for having me here today. So, coming on to the tuberculosis thing tuberculosis has been a big challenge in our country, and we have a huge tuberculosis burden, and we have all these programs to eliminate tuberculosis. On the 24th March, we are going to be celebrating the National TB Day also. So, diagnostic challenge and dilemmas have always been there as far as tuberculosis is concerned. But with the advent of a lot of these newer testing, like the commonly termed like gene expert, which you call, but I think is a line probe assays which have actually changed the way we've been diagnosed. So conventionally, we all are aware that we have been looking for in pulmonary and extrapulmonary. Pulmonary is relatively easier to diagnose. So you do a sputum examination, you do a ZN and a direct fluorescent testing, look for AFBs on that, and make a diagnosis. And now you have the line probe assays where you have things like the TrueNat, the CBNat, the gene expert, which is commonly termed as, which are having a very high specificity and sensitivity. And at the same time, you are able to get the result as far as the rifampicin resistance is available or not. And in TrueNat, you can even get to know about the INH resistance. So as we know, that there is a growing concern of MDR, XDR. So we get a lot of information, and the turnaround time is very short. So within, you do the test in the morning, by evening, you have the results. As far as the extrapulmonary is concerned, most of these tests are being used, but some of them are off-label. They are not WHO endorsed, but they definitely have changed the way we've started, because all this while we've been having the clinico-radiological correlation or a histopathological finding where you are seeing necrotizing granulomas with epithelioid granulomas with necrosis, giving you a diagnosis suggestive of tuberculosis. But now, not once, but quite a number of times, we have burnt our fingers, because there have been cases where they've had lymphomas or fungal infections, sarcoidosis, or other things which are missed. So it is very important that we use these kind of tests. Obviously, we all have ancillary helpful tests like the X-ray, CT, and the PET CT also is a good modality. We've conventionally been thinking about only it is in cancers, but if you see in certain tricky situations, in extrapulmonary tuberculosis, in where you are not sure when to stop treatment, maybe a PET scan can actually help, because stopping treatment also becomes so. If the FDG avidity is gone, sometimes the nodes are still lying there, fibrosis is still there, and you still don't know whether there is active disease or not. When doubtful situation, there you can do. Similarly, body fluids, things, genitourinary tuberculosis. So all these assays are helping, and now we are moving towards things like whole genome sequencing, where you can see the whole genome of the mycobacteria, and you can see what are the mutations present, so you can individualize the treatment. So these are the things which are coming up. Other thing which is very important is non-tuberculous mycobacteria, which we should not be missing in our day-to-day practice. Because if you are getting a sputum smear positive for AFB, or a sample positive for AFB, and the gene expert is coming as negative, you should think of NTM. NTM is not something which is unusual. In the last 1 month, I've seen 4 patients of NTM. So if you have post-surgical procedures, there are patients who have abdominal surgeries, who've had joint injections, who've had, so they are more prone to these kind of infection, and especially in special populations like HIV is more prone to MAC. So you have to think about these things. Anything else, Dr. Tapesh?
So advances in treatment.
So as far as the treatment is concerned, we've conventionally had the 4-drug regimen, which still stands hold good. But the only change in the last few years has been the 2-drug for the initial intensive phase, that is for the 2 months, and then for the next 4 months, you continue with 3 drugs. Earlier regimens used to have only 2 drugs, but now we continue with ethambutol in the continuation phase also. So the standard guideline treatment is 6 months minimum treatment, but you can tailor it, and depending on the organ involvement, you can go on to the treatment for maybe a year or year and a half, depending if it is a CNS involvement, a bone involvement, or there is not clinical resolution happening, or it is an extensive disease. There you can prolong the treatment. As far as the MDR is concerned, there are a lot of shorter drug regimens which are available, but although they are good drugs, the BPAL regimen, all these are available, but they are only available in the government setup, or a very few setups which are partnered with the government. So it's not available in the private as of now. So patients, we have a lot of MDR patients which have to be. So we have these shorter regimens, shorter oral regimen, and you have a longer or a shorter injectable regimen. So depending on the site of involvement, what extrapulmonary involvement. So these are the kind of drugs which are there, and a lot of other drugs like, as I said, the BPAL, whereas the bedaquiline, pretomelide, linezolid, all these drugs are being used and are updated drugs, and generally tolerated drugs. The other new thing which is coming up is the treatment for latent TB, which is very, very important in our current scenarios, especially patients who are immunocompromised, patients who are transplant patients, patients who are going for immunological therapy, patients who are getting the monoclonal antibodies, patients who are on HIV. There you can consider treatment for latent TB, where you do tests like a MAN2 test or the PPD plus an IGRA, or commonly called as the quantiferon gold. So those are the tests which would guide you and help you, and treatment regimens are available in the form of isoniazid plus rifampicin or rifapentin, and they can be used in the special scenarios.
Right, sir. Then thank you for the answer. Moving on to the next question is about malaria, another very widespread infection, just like tuberculosis, you're definitely much more acute. So what is the current treatment of severe malaria with multi-organ involvement?
So you have to see what is the basic organism causing, whether it is the vivax, whether it is the falciparum, whether it is the mixed infection, or whether it is some other, sometimes rarely drug like Plasmodium novel-C or other. So generally, most of the time in Delhi NCR, vivax is the most prevalent, but there are obviously patients who are traveling, especially from Africa or other parts of India, like Chhattisgarh, Odisha, Rajasthan, surrounding areas where falciparum is seen. So, if a patient is having a multi-organ involvement, that is hepatic, renal, cardiac, those kind of things. So the current recommendation is the ACT, that is the artemether combination therapy, where you're using a combination of an artemether derivative plus either you are using, depending on the availability, severity of the disease. As we are saying, it's a multi-organ, so drugs sometimes it may be difficult to give, but sulfamethoxam pyrimethamine or mefloquine or doxycycline, or even rarely, although weaker drug like clindamycin, a combination therapy is what would be recommended, along with if it is a vivax infection. Earlier, it has already always been termed as benign tertian malaria, saying that it's a benign condition. But we all are aware in our practice, and as well, we published long back in 2011 that benign tertian malaria is not so benign. So even vivax can cause multi-organ involvement, ARDS. So in those conditions, also you have to be aware when it's a multi-organ. Then in vivax, you have to do the therapy along. Quinine was sometimes used. Now we are rarely using it and very keeping it as a reserve drug. But there is a growing concern of artemether resistance also. So, but I think as of now, the ACT combination therapy and other supportive measures is what is there recommended as far as the complicated malaria is concerned. Whereas Vivax, if it is a moderate or a minor, mild infection, you can still think of chloroquine if it is if in the area susceptibility is there. But otherwise, it is the ACT combination therapy.
Are you seeing any treatment failure in the sense that patient comes to you with severe malaria and he does not respond in this modality?
So, rarely we have seen patients, especially who are coming from Africa. Those subset of patients have a very difficult to treat infections. We recently have two patients because nowadays people are traveling for business, work, Uganda, other African countries, and there sometimes we, in one odd patient, we had to procure quinine, but which is very difficult to procure nowadays because it's not easily available. But conventionally, most of the time they do respond to, but we have to give it for a little longer period of time and give good supportive care. That is what we've done, and so we managed to get those patients out.
That's great, wonderful. So, about new antibiotics, some new antibiotics have emerged on our scene. Can you please talk about them?
Yes, so there are a few newer antibiotics which are available now in India, although internationally there are certain, but the newer ones are like, which is relatively not that new, but it's been used like ceftazidime, avibactam combination is the drug which is there. The other drug which is there, that is predominantly for the CRE infections, that is the gram-negative infections. So the other one which is there is there is another indigenous medicine which is the cefepime enzobactam by local Indian company Cipla, which is there as a BLBLI combination for carbapenem sparing drug. Then plasmomycin is just around the corner, which is an aminoglycoside, which is probably going to be available very soon, probably next month or so. Then we have the other gram-positive coverage. We have the drug is the levonortifloxacin, which is a gram predominantly for MRSA and gram-positive infection, but it just does cover the sensitive gram-negative bugs also, which is available both as oral and IV, which is also developed indigenously in India. And there are other drugs which are internationally available, but not as of now, is the meropenem and Verobactam plus imipenem relibactam. So these are the drugs which are there in the West, but as of now not available with us in India. But we have quite a few of these drugs which are there, and quite a few are in pipeline as well.
Right. So then moving on to multi-organ failure. So the commonest cause in the ICU is infections. There are probably other causes
What do you
also.
want to do with the 90?
Hello.
Yeah, so there was some. Can you hear me?
Yeah, I can hear you. Sure, sorry. Yeah.
So just to rephrase the question, there are causes of multi-organ failure, commonest being sepsis and tropical
Oh,
infection
yeah.
that we see. You have been as a physician also, so we're seeing other causes of multi-organ failure. Kind of talk.
Yes. So we see, yeah, so we do see a lot of non-infective causes as well. So non-infective causes is the most common being the autoimmune disorder. So disorders like, lupus. So lupus may present with a SLE. Lupus may present, especially in younger females, will present with multi-organ in the sense, especially renal involvement. They will have renal involvement. They will have hematological involvement, joint involvement, and they may have lung involvement. Rarely they may have present as pulmonary hemorrhages. We've lost some of the young. It's very devastating and very difficult because it's happening in a young 20, 25-year, 18-year-old girl who presents with pulmonary hemorrhage, renal dysfunction. So there are cases like GPA, which was earlier known as the Wegener's granulomatosis. They may present with cavitation in the lung, with renal involvement, hematuria, renal dysfunction. So these are one which are common. The other thing is obviously they can present with poisonings. So you can have poisonings which can cause multi-organ failures. A whole lot of poisonings. Even snake bite, often on you don't see much in Delhi, but once or while you do come across. So snake bites can present with multi-organ involvement, neurological involvement, hematological involvement, depending whether it's great cobra or snake bite you have. So you do come across these kind of things in the ICU setting, apart from the sepsis or the infection or the usual things.
Great, sir. So multi-organ failure due to autoimmune diseases, poisonings, and snake bites and envenomations should be considered.
Even drugs also, not to
But drugs causing,
Steven Johnson's or TENS, and they can present with Steven Johnson or address syndrome. So that also you see once a while. Yes.
great, sir. So moving on to COVID, then, sir. We have been able to get out of the epidemic that was there, but now there has been some buzz, especially in the Western literature, about long-term sequelae of COVID. Brain fog and other things. So, are you seeing long-term COVID, and is it leading to mortality?
Not really to a large extent, but yes, some of the patients have correlated their problems, that they've had lung problems, they have recurrent infections. We have had patients who had some amount of autoinflammatory disorders, where autoimmune disorders were triggered because of either it is the COVID or the vaccine. We don't know. They do have some amount of triggering of the autoimmune disorders. They have a certain amount of residual lung disease. They have certain amount of issues regarding their earlier illnesses, multiple illness which they feel have been progressive. Pre-diabetics went on to become diabetics, or so these are the kind of things which are prevalent to some extent in our clinical practice.
Right, sir. Moving on to anemia, sir, another thing which is very common. Patients often come to the ICU, hemoglobin 4, 5, 6, not uncommon at all. And sometimes they are in heart failure. Anemia is severe anemia because high output, high cardia, has cardiovascular manifestations. There's always been some controversy whether severe anemia can lead to heart failure. Does it lead to heart failure by itself, severe anemia, or there is a precipitating factor, sir?
So, generally, if it is a very long-standing anemia, the patients do compensate for that. Indian population has a lot of resilience, especially the ladies, they keep running. But yeah, definitely, severe anemia can precipitate heart failure. High output heart failure is not that it's mentioned in the books, it is also mentioned. Yeah, but generally, as I told, it's chronically there. So they get used to it, but there may be an additional trigger which may precipitate the event, like an inadvertently infection or another nutritional deficiency or another disease which may precipitate it further. But yeah, per se, severe anemia with hemoglobin of 2 grams, 3 grams. So I've seen a lady way back in my residency days. She was having an hemoglobin of 2 grams. She was breastfeeding and not able to breathe, but she was breastfeeding and she was 2 grams. So we are amazing, but it definitely it can cause heart failure, and an added on infection or things can trigger the event even and worsen the whole process.
Yeah, and probably, sir, also I think the acuteness of the development of anemia also may be important. How, because
Yes,
if with
yes,
then they probably adapt to it, something like that.
yes, 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 yes.
So then moving on to the next question is about addiction. A lot of our patients, they chew tobacco, they are smokers, and in the ICU, they go to the ventilator. When they're on the ventilator, they are on sedation. So they are, not awake for some time. Then the sedation, they get up and suddenly they are restless and all those things because of withdrawal. So can you just talk a little about this withdrawal from nicotine, in terms of gutka or smoking and how to treat it?
Nicotine, vodka, alcohol, all these are challenges in patients who are ventilated. They are difficult to, because if somebody has a lot of high alcohol consumption or other drug intake or these kind of things, so what happens is that the drugs which you are using for sedation, the dose requirement also goes up because their threshold is very high as compared to a normal person. So somebody who's taking a lot of alcohol every day will be causing a problem. Similarly, for these problems, so sometimes it becomes difficult to wean them off, and it is a challenge. So we have to, involve strategies patient to patient depending on the kind of dependence, how difficult it is. So we have to get a strategy individualized to that patient. So they may take a more longer period to extubate or to wean off, or giving drugs like fentanyl, we have to avoid sometimes, or to get them off becomes difficult. So those are the challenges which one experiences when these kind of addictions are there in these patients.
So, I think, sir, for nicotine withdrawal, probably you can give them a patch, a nicotine patch or something.
Actually, yeah, sometimes we do have to use nicotine patches for patients who have a very high, like patients who are taking 10, 20 cigarettes a day, or a lot of their nicotine patches are also available, which do help to some extent. But yeah,
Okay, sir. So great, sir. Thank you for all your dissemination of knowledge and explanation of concepts. Thank you very much, and thank the audience for their joining in and patient hearing. Thank you, Dr. Gogia, sir.
thank you so much. Thank you for having me. Thank you so much. Have a great evening and great night. Thank you.